Thank you, Dr. Suarez. Dr. Chandrikha Chandrasekharan is our next speaker. She's a clinical associate professor at MD Anderson Cancer Center, where she's focused on neuroendocrine tumors and pancreatic cancer. She is a dual board-certified physician in medical oncology and palliative care. She's going to talk today about genetics, risk of other cancers, and survivorship beyond diagnosis.
Hi, everybody. My name is Chandrikha Chandrasekharan. I am a clinical associate professor at MD Anderson Cancer Center in Houston. I've been asked to present on this topic of genetics, risk factors, and survivorship in neuroendocrine neoplasm. It's beyond diagnosis. It's multiple topics to cover. I'm going to try to touch upon briefly some of these as we go along. So when we talk about neuroendocrine neoplasms, I wanted to make sure we're not just covering like the gastroenteropancreatic neuroendocrine tumors, which is the more common pancreatic or the stomach or small bowel origin neuroendocrine tumors. As you can see in this slide, there's a whole bunch of cancers that can arise in different organs in the body that all come under that neuroendocrine cell origin. So for example, medullary thyroid carcinomas, which is a specific type of cancer, the thyroid gland is also a neuroendocrine neoplasm. Pheochromocytomas, which are gland arising in the adrenal medulla, that is a special gland in your body, or paragangliomas, those are also neuroendocrine neoplasms. And then in this purple color box, you see a whole bunch of other organ sites and other types of neuroendocrine neoplasms. So when you talk about neuroendocrine neoplasms, especially the risk factors and genetics, as you can see, there's a whole bunch of things here, and it may be hard to find a commonality or like unifying factors. So the discussion may go back and forth in some specific types of neuroendocrine tumors. So when we look at the incidence, this is an often displayed slide pretty much in every talk by Dr. Dasari at MD Anderson that looked at SEER incidence, which is like this large registry of different type of cancers registered over the decades. So the incidence of neuroendocrine tumors and published in 2017 when compared to 1973 versus 2012, at which time this analysis was completed, showed almost like a 7-fold increase in number of patients diagnosed with neuroendocrine tumors. Now, if we look at the actual types of neuroendocrine tumors in this next slide, the steep increase is primarily for not all locations. It was mostly lung in that reddish curve, and then the high incidence in rectal neuroendocrine tumors, as you can see in the black curve. So that's two neuroendocrine tumor types that significantly has increased incidence in this time period. And then again, fortunately, when we look at the type of neuroendocrine stages, majority of this early detection has been in the localized neuroendocrine tumors, those that are still confined to the organ. If you look at the distant or spread neuroendocrine tumors, it's not as steep of a curve, it's more relatively flat. So we've been diagnosing more, but more lung and rectal and also appendix, and also mostly localized neuroendocrine tumors. When we look at more recent data published just recently as June 2025, which also looked at the same SEER database, which is United States, from 1975 to a more updated time of 2021. The age and adjusted incidence rate is still going up, almost increased 5.2-fold. And if you look on the left, the blue curve is multiple other cancers. And then the yellow curve that you can see here is actually the neuroendocrine tumors, which you can see has got a steep increase in the incidence. Now, this increase is across all sites, stages, and grades. But the largest increase is actually in the appendix neuroendocrine tumor, which is this faint green curve that has gone almost astronomically high. Again, this is raising a lot of questions about this increased incidence. Is it actually a true increase, or is it a case of overdiagnosis of early stage disease? And I'm bringing this up because when you're talking about survivorship, there's a lot of focus you see on other cancers like breast cancer survivorship, colon cancer survivorship, because there are also more patients diagnosed with that cancer numerically still. But neuroendocrine tumor is not very far behind. The number of patients living with this cancer will increase likely. And then the whole concept of survivorship after you're diagnosed, living with this cancer, that's an important topic that we have to focus on. So when we look at this increasing incidence of neuroendocrine tumor, the question that comes up is it a true increase, or is it an increase because of actually more techniques of diagnosis, better registries, or some of these factors that are discussed here? Because what we have seen is this increase in incidences more to the specific types of neuroendocrine tumors as well as early stage. The increase in the metastatic stages, basically the advanced stage, is relatively stable. The incidence has been stable. So this diagram here kind of talks about potential factors that has maybe led to this increase in incidence. One of the factors potentially for the increase in incidence could be improved diagnostics, whether this be more endoscopies and colonoscopies or other imaging studies like CT scans and MRIs that we are doing for more reasons. Another potential reason, as you can see, is the advances in data reporting. Across the world, we're doing a better job of classifying these tumors, naming them, and maintaining tumor registries that has led to a better capture of data. And there are also some comorbid conditions or risk factor associations that we will discuss later. For example, there's definitely been an increased incidence of gastric neuroendocrine tumors associated with increasing use of proton pump inhibitors like pantoprazole, omeprazole type of drugs. Whether there's a true increase in other risk factors and neuroendocrine tumors is unclear or less clear. The genetic factors, we have probably gotten better at diagnosing and also capturing this better over time, but their relative incidence is probably the same as it has been, less likely to have led to this increase in incidence we are seeing. The next slide will talk about some of the other non-genetic risk factors. Like I said, majority of the neuroendocrine tumors are still felt to be sporadic. They are not inherited. So then that brings the question if there's an increase, maybe because of lifestyle factors. But if you look at what's being studied, this is actually one area of unmet little research done in neuroendocrine tumors because these lifestyle factors are not very well defined in the context of neuroendocrine tumors. So, there's a review article that I've listed here that brings together the diabetes, smoking, alcohol, family history of cancer, and the OR mean the odds ratio. So having diabetes, the increased odds of having a neuroendocrine tumor is 2.74, especially if it's recent onset diabetes. Now, whether this is an association, because if you have a pancreatic neuroendocrine tumor, which affects the function of the pancreas and the insulin secretion, that can lead to diabetes being diagnosed around the time of the cancer, not just neuroendocrine, also adenocarcinoma, the other kind of pancreas cancer. So whether this is causative, meaning it causes, or is it associative, it is just an association, probably more at this time the association. So these are the factors that are unclear. Now, there is family history of cancer is definitely important, not just of neuroendocrine tumor. There are studies that have shown that other cancers like pancreatic adenocarcinoma in the family can increase the odds of a patient or person being diagnosed with neuroendocrine tumors or hepatobiliary. These are a couple of the ones. There's also some associations reported with renal cell carcinomas. Now, is it because there's actually a genetic factor that we haven't identified, or is it because families that live together in a shared environmental exposure get exposed to the same risk, again, leading to this cancer? That's also unclear at this time. Now, smoking and alcohol, there are equal number of studies, even though the studies are very limited, of both associating a higher number with neuroendocrine and absolutely not associating with neuroendocrine tumor. So I think we cannot really conclude much with the studies we have. Obesity, again, or increased body mass index has been studied in only one or two papers that I could find. And again, there's not a very clear association. So really, from a lifestyle perspective so far, whether this causes neuroendocrine tumor or associated with neuroendocrine tumor, those are unclear factors. But something I'm hoping that we will be able to find out more with more studies in the future. Now, patients come in and they say, oh, I've had testing done, genetic testing done. But then if we go and ask questions, a little bit confusing whether they had inherited or germline testing or tumor testing done. There are multiple platforms out there, so I think it's important to try to know what exactly was done. Was it the tumor that was tested? Was the tumor and the genetic or inherited mutation that was tested? Now, there are platforms that can do both in the same test, basically get the tumor and your blood sample and do both. So again, as more and more platforms are available, I think it's important for the patient also to be aware of what was done. So when you're talking about a germline mutation, this is essentially present in every cell of the body, and it was something that was passed down through generations, parent to offspring. It can increase the susceptibility of the cancer, and it can also usually, based on the gene that's affected, cluster to a specific type of cancer groups. And usually it's tested in a blood or saliva sample. When you're talking about a somatic mutation, this is essentially referring to the mutation that's found in the tumor cell. So something went wrong as the cells were dividing in the cell, and that led to proliferation and a cancer. So this is not present in every part of your body or every cell of your body. This is typically also not passed down through generation. And this is often tested in the cancer tissue, but there are also testings available now to do it in the circulating tumor DNA or blood test as well. So this is important difference when you're talking about mutations. So I'm going to focus on the germline or genetic mutations and go by specific ones as well as the specific tumors. When you look at pancreatic neuroendocrine tumors, approximately 10 to 15% of pancreatic neuroendocrine tumors are associated with a genetic syndrome. I've listed the four most common ones or more well-defined syndromes. Everybody is probably familiar with the multiple endocrine neoplasia, the MEN syndrome as it's referred to, which is based on this mutation in this gene, menin, which can often lead to gastroenteropancreatic neuroendocrine tumors, parathyroid adenomas, and pituitary problems. Majority of them are non-functional, but a lot of times they're associated with what we call the Zollinger-Ellison syndrome, which is the hypersecretion of the gastrin hormone in pancreatic neuroendocrine tumors. The other common associated pancreatic neuroendocrine tumor is 1 hippolindo, and this is actually, again, not as common, but you also see a cluster of findings, usually pheochromocytoma, pancreatic neuroendocrine tumors, kidney cancers, and retinal hemangioblastomas. These are basically some dilated blood vessels that can be picked up, one of the first presentations of this syndrome. Neurofibromatosis 1 is another such complex associated with neuroendocrine tumors, as well as tuberous sclerosis complex. These are the ones associated with pancreatic neuroendocrine tumors. When you look at small intestine neuroendocrine tumors, actually the vast majority are sporadic. However, there have been studies going back to 1950s in the Nordic population, which is one of the large databases in the country, that show that a 9 to 11-fold relative risk in first-degree relatives representing a shared genetics and environment. Again, it could be genetic inherited risk through families as well as the shared environment, but yes, there is definitely association with high risk in the family. Now, if at all you see a genetic association, it's often MEN1 associated, the first syndrome that we talked about in the pancreatic as well. Lung neuroendocrine tumors, again, the vast majority are sporadic. In MEN1 syndrome, 2 to 8% may have lung neuroendocrine tumors. But the majority of them are, again, the well-differentiated typical carcinoid, the less aggressive kind with good prognosis and a very indolent course. In fact, there's data just like the pancreatic neuroendocrine tumors that some lung neuroendocrine tumors associated with the MEN1 may be also observed for a long term safely. Now, thymic neuroendocrine tumor, a lot of people ask, what is a thymus? So thymus is this gland that you see kind of tucked in behind your breastbone or behind the lung. Normally, your thymus tissue, which is involved in your immune system, involutes or kind of regresses as you age or grow, but sometimes they may persist, the thymic tissue persists, and neuroendocrine tumors can develop. This is definitely a rare subset within the neuroendocrine, but nearly 25% of the thymic neuroendocrine tumors are associated with MEN1 type. And they can be functional, a little bit more aggressive course, more likely to metastasize as well. And because of the location, surgical resection sometimes becomes difficult or challenging in this group of patients. Looking at medullary thyroid cancers, I don't treat medullary thyroid cancers, but just important to know because I do see patients with MEN syndrome that also have medullary thyroid cancers. Typically, we're talking about type 2A, type 2B, and 25% of medullary thyroid cancers have a hereditary cause. And the gene that's implicated is RET gene. So if you have a MEN2A inherited mutation, there's a 90% chance of getting a medullary thyroid cancer. On MEN2B, it's almost 100% at a young age. Next, we'll move on to pheochromocytomas and paragangliomas. These are neuroendocrine tumors that arise in the adrenal medulla. So adrenal glands are little tiny pea-sized glands on top of the kidney. The medulla is referring to the center of it. This is kind of an extended part of your nervous system, sympathetic and parasympathetic system. So they kind of secrete some hormones. We refer to it as the flight-fight hormones. So when the tumors arise in the adrenal gland itself, in the middle of these are pheochromocytomas. When they're arising in these ganglion, which is basically like structures containing some nerve cell bodies scattered throughout your body, then they are the paragangliomas. These are at least 40% of them are associated with some kind of a hereditary syndrome. And the big ones are VHL, MEN2, like we talked about, neurofibromatosis, and also this cluster of syndrome we call hereditary paraganglioma pheochromocytoma syndromes, implicated genes like SDHA, BC, and then there's a whole bunch of other rare mutations that I have not mentioned here that are now discovered and can be tested. So any patient with pheochromocytoma or paraganglioma or medullary thyroid cancer needs genetic or germline testing to be performed. So a little detail about the MEN type 1, type 2A, and then the VHL, because these are a little bit more common. And then I'll move on to the survivorship topic. So MEN type 1 is characterized by what we call the easy to remember tumors of 3 Ps: parathyroid glands, pituitary adenomas, and pancreatic islet tumor cells. The prevalence is approximately 2 per 100,000. Now, though the 3 Ps are defining tumors, as you can see in this picture here, there are multiple other benign spectrum tumors that are also associated with MEN type 1. The lipomas, which is basically fatty tissue. Again, the vast majority I want to emphasize are not inherited, just that these can be found in MEN type 1 as well. So just having a lipoma and a neuroendocrine tumor does not automatically mean you have an MEN type 1. There's a cluster of things that come together when you have a gene mutation to need the testing. So then the MEN type 2A and 2B again has a few variants to it. The mutated gene here is RAT or RET. Again, within the type 2A, there's a classical type 2A, which is basically the thyroid cancers, medullary thyroid specifically, pheochromocytomas, 40 to 50%, and primary hyperparathyroidism, which is again the parathyroid gland causing hypercalcemia and other problems. There's some skin manifestations in the MEN2A with the cutaneous lichen amyloidosis. These are some skin changes that you can see with darkening pigmentation. Hirschsprung disease with some colon disorders, and there's also the ones that have without the pheo and the parathyroidism, just the medullary thyroid cancers. And then there's type 2B, which is defined by medullary thyroid cancers and the pheochromocytoma, and also some non-cancerous other type of tumors like these that are rare. So again, these are rare syndromes still, but definitely there's a classic family history that prompts you to test patients. The other common one that's important to know also, because this is one of the genetic syndrome now actually has a drug, 1-hippolindo. This is a VHL gene. The prevalence is about 1 in 36,000. It's a little bit more common. About 10 to 20% of patients with VHL will develop a pheochromocytoma. Median age is about 30. Pancreatic neuroendocrine tumors, about 9 to 17% of them will develop, and majority of these are non-functional, low-grade, well-differentiated, can be unifocal, meaning like a single tumor, or multifocal, and oftentimes have good prognosis. Like I said, there's other things that are associated with the VHL mutation. The drug that has been approved, belzutifan, this is a drug that is an oral pill, which is a small molecular inhibitor of this HIF2 alpha, like a particular pathway that is aberrant in this VHL gene mutation. It's approved for all tumors related to this VHL gene, including neuroendocrine tumors. And the results are very impressive, even sometimes complete response in some of these neuroendocrine tumors if the gene is present and is the driving force of that mutation. So I want to move on to survivorship, and kind of that's the last part of the topic. So when you're talking about the increased incidence or the increased prevalence with or without the genetic factors, there's whole question of survivorship comes up. Now, every patient, every person, every healthcare professional defines survivorship or a cancer survivor very differently. But I think this is the definition used by the Cancer Survivorship Institute of Medicine, NCI. It's very comprehensive. An individual is considered a cancer survivor from the time of diagnosis through the balance of life. There are many types of survivors, those that live with the cancer, those that are free of the cancer. So this is to capture a population of those with a history, basically anybody who's been touched by cancer personally at any point, not the patient. And it's not really meant to provide a label that may or may not resonate with individuals. This is a definition so we can capture these patients, provide them the resources, include them in research, and do a good job of serving them. So this is by no means the definition of what you consider as a cancer survivor, and I respect everybody's definition of how they identify themselves in this journey. But this is just to capture, like I said, data, and also to make sure we have resources available for this group of population. So when you look at the survivorship aspects, there's multiple aspects of cancer survivorship. It is a state of being that includes the perspectives, the needs, and the health, and the physical, psychological, social, and economic challenges. I think a lot of times healthcare physicians, providers kind of end up with the physical challenges and maybe sometimes with the psychosocial challenges, but we definitely do a very poor job of addressing the social challenges or the economic challenges that cancer diagnosis brings to the patient. When you look at the care spectrum, comprising all of those needs that we talked about or discussed in the previous slide, you have to go beyond just treating the patient in that moment. We have to look at monitoring and recurring for new cancers or other primary cancers. You just don't have to talk about treating the cancer. You have to talk about how can we promote healthy behavior. We have to coordinate care between multiple disciplines. We have to manage the non-cancer problems like diabetes or hypertension effectively so we can do a good job of treating the cancer itself. We have to discuss the goals of care, the individual preferences of the patient or the caregiver and the family as a unit. And we have to remember it's not a single person's job, so offering support services. And as we talked about already, genetic risk assessment. So we are also addressing the next generation and hoping to be more vigilant. And then the social and the financial impact. Now, these are, again, like I said, aspects that are not very well addressed in multiple situations and in multiple aspects of the care. I want to really talk about what's unique in neuroendocrine tumors with that framework. This is my impression of what are unique challenges in neuroendocrine tumors. I think a lot of patients will agree that, it's the delay in diagnosis, even though the survivorship here is defined as when you're diagnosed with a cancer. In a neuroendocrine tumor situation, a lot of patients have symptoms for years. So maybe the survivorship has started actually from that time, not after you've had an official label of cancer diagnosis. What is also unique in neuroendocrine tumors is this indolent nature that also means there's longer survival, which is great, but then there's a cumulative burden of cancer that the patients deal with that is very different from some other types of cancers. When you look at then the unique burden of a functional neuroendocrine tumor, like the diarrhea and the flushing that comes with it, this is an additional burden that we have to help the patients with just by having a tumor, nothing to do with the treatment we give, but we have to remember this is different about neuroendocrine tumors. Then we look at also toxicities of therapies, but because it's an indolent cancer, we have to look at both long-term and short-term toxicities. And then there are a lot of uncertainties in prognosis. I think this is one of the hardest questions for me to answer in clinic. What is the prognosis with my tumor? There's also uncertainties in the therapeutic algorithms. In many other cancers, we have a little bit more guidance on first line therapy, second line therapy, and third line therapy, like the order in which we go. But neuroendocrine tumors, there's no good algorithm, so it's confusing for the patients as to what to do next. And again, I think even physicians, for these reasons, sometimes don't get involved in neuroendocrine tumor research or practice for similar reasons. And then, just like any other cancer, but more so in neuroendocrine tumors, there's multiple disciplines involved. And then there's also multiple health systems. There's a primary oncologist maybe involved with your regular care. There's a neuroendocrine specialist that's involved. There's maybe a surgeon in another institution that's involved. There's could be an interventional radiologist involved, or tissue may be sent out for pathology to a different system. So multiple health systems as well as multiple disciplines. With the indolent nature, long survivals, it's also clearly known that there's a secondary cancer risk in patients with neuroendocrine tumor. So we have to be aware of the screening and other things that we need to continue in patients with neuroendocrine tumors. Again, the financial impact, when you're talking about long-term longitudinal burden this cancer carries, whether it's a functional or non-functional, number of visits, number of CT scans, the distance traveled to a neuroendocrine tumor center, the flight tickets, or the miles spent on the road for the patient, caregiver, the family member, there's a huge financial impact that's not captured with this type of an indolent cancer. And then when you talk about even patients who've had a curative intent surgery, you're not talking about 3 years surveillance or 5 years surveillance. You're talking about at least 10 years per guidelines. And that's longer than most other cancers, and then technically even beyond. So this surveillance, even in those that are quote cured, goes beyond the usual cancer. So these are unique challenges to neuroendocrine tumor. There are multiple studies that looked at unmet needs in neuroendocrine tumors. This is one of a global survey. Now, what's interesting in this particular slide is on the black color here is the patient's reply, and the gray is the patient advocates, and then the other bar is here the healthcare team members. Clearly, as healthcare team members, we don't perceive the unmet need very well. We don't. We are. It almost seems like tone deaf to the unmet need of the patient or the patient advocates here. So there's a high amount of unmet need in the information spectrum in psychological care, the research, availability of clinical trials, management, pretty much in every aspect that was quizzed, there was a very high unmet information need. When you look at the care needs, this is actually where is the gap in receiving care. Again, healthcare advocates slash the patient advocates, maybe the patients don't like to speak up more. Again, a good reason to have a caregiver with you in these appointments. They perceived a high unmet care need in multiple spheres here. So this has been replicated in multiple studies in multiple countries. It's a study out of Australia that looked at 69% not understanding even when information was given what was given. Most accessed online, but 2/3 do not find it useful. And even after 6 months, even though the anxiety of a diagnosis seemed to have decreased a little bit, majority of the other psychosocial outcomes, care experiences were similar to what was at baseline. And there was definitely worsening financial problems like we discussed compared to the baseline. Another big study out of Canada, similar results. Even after 5-year follow-up, like you can see longitudinally of multiple symptoms, anxiety, which seemed to have slight improvement after settling down with a treatment plan maybe, but then there's persistent tiredness, fatigue, and then a sense of low well-being and depression, even after 5 years of living with a neuroendocrine tumor. So this is a very nice first guideline that was presented in 2005. Certainly we've come some a long ways, but there's a lot left to do. To conclude, two things. What can we do, we as in the healthcare team members? I think we should make sure we provide a treatment summary and a care plan to every patient, every survivor, and then take time to know the person, not just the patient, not just the neuroendocrine tumor. I think we have to develop these relationships in any cancer, but it's more so important in neuroendocrine tumors where you're going to know patients for years. Let patients not be the messengers between the teams. I think this is often a practical thing that happens where, well, we'll send the notes, great. If the notes are reaching your primary oncologist or another team member, great. But if not, if necessary, pick up the phone, communicate with other team members when something important is being done, like a treatment change or treatment recommendation is made. But let patients not be the ones carrying this message between the teams. Address the psychosocial needs. Again, you cannot address it all as a single oncologist or a surgeon. Involve other team members appropriately, offer these services to the patient. Comprehensive care. So it's not just medications, mind, body, and soul healing. Prevention, surveillance, and detection of new and recurrent cancers. Try to tell patients just because you have neuroendocrine tumors, don't forget your other health issues. Don't forget your colon cancer screening, your mammograms, whatever they need, depending on where they are in their neuroendocrine tumor journey. And then also, like I said, we have to make sure we're addressing the well-being of the patient and including their non-cancer medical conditions. But it's perfectly appropriate to tell the patient, this is something that I'm not comfortable because I'm not the expert. You should discuss with the primary care, but it's important to your neuroendocrine care as well. So the patients can take this back to their primary care as well. Assessment of their lifestyle behaviors. Again, one clinic visit is not possible to cover all these topics, but along the multiple visits we have over the years, hopefully we can address some of these topics with the patients depending on the priority that the patients present with. Advanced care planning. Sensitive topic discussions. Now, sensitive topic discussions could involve end-of-life topic discussions, financial matters, how the neuroendocrine tumor affects your social functioning or sexual functioning. These are topics that we often don't bring up, but it's, I think, okay and important for the patients to hear from us that it's okay to talk about it as well. Involve the caregivers, get to know the caregivers, and always emphasize shared decision making. Now, also, I wanted to think about a few things that the patients can do in their survivorship. Ask for a clear plan. Make a follow-up appointment if it's not clear so you can clarify the plan. As you know, visits can be rushed sometimes, and if it's not clear, it's okay to make that follow-up appointment if needed, if it's not urgent. Verbalize your needs and priorities. Sometimes if we don't bring it up, you can also bring it up. What is important to you in that moment, in that decision, in that clinic visit, you have to bring it up. Also, use the time wisely. Prepare for your visit. I think it's important because you also want to make sure you use mind charts and other methods of communication wisely and appropriately. If there are things that can be held and saved for the next visit in person, that's a great way of doing things if it's not urgent and pertaining to your immediate care needs. I think as healthcare providers, we are also burdened by multiple messages, and this is something that the patients can help us so we can provide better care when we see you in the clinic. Prepare for your visit. Again, communicate. We may not have all the answers, but we should listen. We can listen. And then the biggest thing that most patients have with cancer is lack of control. But control what you can. Control nutrition, activity levels, adherence to care recommendations, anything that you can control, it's yours. Remember, it's teamwork, not just your healthcare, but also within your family, caregiving, whether spouse, friend, whoever it is, you have to find your team. You have to find your team in the healthcare spectrum as well as in outside of the hospital, outside of the clinic, at home, at work. And that's helpful. To conclude, I think for neuroendocrine tumor, this is a very apt summary of how every stripe of a zebra represents a step in the story of survival. And all these words that come up when you talk about survivorship that are also applicable to neuroendocrine tumor. Courage, persistence, survival, fighter, hope, healing. Thank you.